Our guest today, Dr. Sandro Galea, is joining us from his office up in Boston. And so, for those of you who've listened to previous podcasts, if it sounds a little bit different today, Sandro is our first guest who's actually completing his podcast via phone, but we're still really excited to have him here. Hello and welcome to the M.V.P, the Mass Violence Podcast, the official podcast of the National Mass Violence Victimization Resource Center, where we discuss all things mass violence from readiness, response, to recovery. I'm Dan Smith, the NMVVRC Director of Resources and Technology, and with me today is Dr. Sandro Galea. Dr. Galea is a physician, an epidemiologist, and an author. He's also the Dean and Robert A. Knox Professor at Boston University School of Public Health. And previously, he's had academic leadership roles at a few institutions you probably have heard of, including Columbia University, the University of Michigan, and the New York Academy of Medicine. Not too shabby. He's a world-renowned expert in the areas of public health, the impact of trauma, and the social causes of health. His most recent book, which I just cannot recommend highly enough, is called Well, What We Need to Talk About When We Talk About Health. I'm sure we'll talk more about that book in just a minute, but I'll just sum up my introduction of Dr. Galea by saying that I've known Sandro for just about 20 years now, and he is without doubt one of the most brilliant people I've ever had the privilege of knowing and collaborating with. But perhaps even more impressively than that, he's actually been retweeted by the founder of the Huffington Post herself, Arianna Huffington. How did that happen, Sandro?
Well, Dan, thank you for having me, and this is a very kind introduction. Arianna and I have connected at meetings over the years, and I actually think that she has been writing and thinking about all the things that I've cared about. And in her latest business venture, which is around Thrive, it's really about behavioral health fundamentally. And so I actually think we have a lot of ideas in common, and we have enjoyed conversations over the years.
That's awesome. I totally fanboyed out when I saw that, though. I was like, oh my God, I know him. He's being retweeted by Arianna Huffington. Okay, so I kind of wanted to start pretty broad, Sandro, and then sort of zero in a little bit on the violence connection. I'm fairly confident that most of our listeners have heard of public health and kind of have a general sense of what it is. They probably associate it with things like vaccines and anti-smoking campaigns and the like, but as an expert in the area, what is your definition of public health?
You know, whenever I'm asked what public health is, I have come to define it by telling a story, which is a story that I tell in the book Well that you refer to. And the story, very quickly, is one of blind Willie Johnson, who was born in Texas at the turn of the 20th century. He became blind in a domestic violence incident when his stepmother threw a lie in his face. He grew up poor, and his house burned down when he was a young man, and he kept living in the burnt-out shell of a house because he didn't have any money. And when he was in his 40s, he developed malaria. Now we're dealing with Texas in the 1940s, where malaria was not all that uncommon. And his wife took him to hospital, and he was turned away from hospital. And then he died. And the reason I tell the story is because obviously what killed blind Willie Johnson was malaria, because had he had treatment for his malaria, he would have lived. But it is clear that the forces that killed blind Willie Johnson are not just malaria, but it's also domestic violence and racism and homelessness and poverty and access to care. And that's what public health is about. Public health is about all of those forces. And clinical care and treatment is a part of what makes us healthy. But public health is about the broader context around us.
Excellent. Okay, so you're obviously an expert on public health. You're also one of the NMVVRC's sort of lead academic consultants, and so maybe make that connection for us. You know, the NMVVRC is focused on mass violence, obviously. What is the relation of large-scale violence to health? I mean, I suppose there are some obvious connections, like the people who are victims of violence get hurt and their health is affected. but are there broader or more indirect connections between violence and health?
I've always thought that trauma and violence are one of the most immediate links between the world around us and health of individuals and health of populations, and for many reasons. Number one, trauma is nearly ubiquitous. More than 90% of the population will experience trauma at some point in their lives, and there are actually relatively few forces that are as common as trauma. Number two is that trauma, by definition, is a product of the social world. Trauma does not just happen. It is a product of the world in which we live, our social interactions, how we structure our society. So as a result, trauma is a reflection of our social and economic structures. So to my mind, trauma and violence are one critical link between social and economic environments and our health. So I've always found it entirely consistent to be interested, as I am, in broader social economic context and in trauma and how that affects health.
Okay. So explain, if you can, I know this is kind of a broad question, but how do those connections manifest? Are we talking about mental health or physical health or some combination?
We're talking about both. I mean, the health consequences of trauma include not only mental health, mental illness, but they also include chronic disease like heart disease, lung disease, diabetes, obesity. And we know that the divide between mental health and physical health is ultimately arbitrary. It's a distinction of convenience, and one that has emerged just because these fields have evolved separately. So I do think that that trauma is associated with the full range of health. I mean, there are data, some from our group, some Ben you've done, some other people have done, that show fairly convincingly that trauma is linked to mental health, and that mental health is then linked to worsening of other physical health conditions. You are more likely to be diagnosed with the full range of physical health conditions if you have mental illness, and your recovery is likely to be slower. So we are dealing with physiologic processes that are disrupted by trauma and that affect both mental health and physical health.
Okay. So that makes a lot of sense, particularly for those folks who've been more or less directly exposed to trauma, directly exposed to a personal experience of violent victimization. I'm wondering if you saw, and unfortunately I don't have the study right in front of me, but it was, I believe this past fall, there was a survey done, and it was something like 48% of the population viewed themselves as being at risk for a mass violence event. And that's probably a gross overestimation of the actual likelihood that someone would experience a mass violence event. But to us here, it sort of spoke a lot to the potential impact of fear and anxiety and avoidance behavior on just sort of how we live our day-to-day lives. Does that factor in at all, do you think, into sort of how a public health professional might describe the role of violence in determining health?
I do think so. I do think so. I mean, you're absolutely right that I think we tend to overestimate our risk of being exposed to mass traumatic events all the time. And for example, we are terrified of things like school shootings correctly, but the truth is we're likelier to get hit by lightning than we are to be in a school shooting. And so it is anxiety and fear that colors how we see our risks. And we are at greater risk of experiencing trauma at the individual level at the hands of an intimate partner, for example. Every minute, 20 people are victims of some sort of violence committed by an intimate partner. 1 in 2 women experience sexual violence at some point in their lives. I mean, these are much more ubiquitous forces. So I do think that there is a mismatch between the forces that truly shape our health and our perception thereof.
Yeah, that's an interesting distinction, and one that I think I need to spend a little bit more time thinking about, because that whole role of fear. One of the things I took away from reading your book was just sort of how focused it was on things that we know make us healthier, as opposed to things that we know that cause disease. And that's sort of got me thinking along that lines of, fear and anxiety are just not really health promoting kinds of states to be in all the time.
No, of course not. And the book's subtitle, which is very intentional, is what we need to talk about when we talk about health, because the aspiration of the book is to really try to change how we talk about health, and part of that trying to change is moving us beyond talking about healthcare to talking about health, which are quite different things, and we perceive these things differently. We have had an overwhelming investment in doctors and medicine, and that overwhelming investment has made us see health as a private commodity, something that we can buy and sell. But of course, we cannot buy and sell health. What we can buy and sell is healthcare. Health ultimately is a state of not being sick to begin with, and if we are to move to a health system instead of a sick care system, which is what we currently have, we need to invest in the preventive conditions of health. We need to invest in safe houses, in good schools, and livable wages, and gender equity, clean air, drinkable water, fair economy. And those are the forces of public health. Those are the forces that create health.
You're almost, it's like you're reading off the questions I have prepared for you here, because that really was a great segue. One of the things I was going to ask you about was how in the book you talk about how, at least in the United States and certainly in some other countries as well, we've basically adopted an individual approach to health promotion, right? I'm going to go to the gym more often. I'm going to cut fat out of my diet. I'm going to eat healthier, eat macrobiotics or whatever. But that whole approach generally has been unsuccessful. And I'm just curious about what you think people should be doing. And by people here, I guess I mean individual people as opposed to sort of social structures. Or maybe there's a question in there about how individuals influence social structures to make the kinds of changes and move towards a health promotion society than a sick care society.
Yeah, you're embedding a lot of questions in that.
Yes, not good interview technique.
It's number one. We know that individual behavior change works far less than we think it does. We have a vastly overinflated sense of how much individual behavior change works. And my favorite example of this is one of the biggest successes of health in the past century, which is motor vehicle deaths. And motor vehicle deaths have gone down. Your chance of dying per mile you drive is down more than 200-fold in the past century.
Wow.
But the reason for that is not because we're better drivers. The reason for that is because of our cars. Because of cars, because of seatbelts, because of airbags, because of shatterproof glass, because of laws that do not allow us to drive while we're under the influence of alcohol. So it's a classic case where the fundamental behavior, which is driving, probably hasn't changed very much, but we've changed the world around it to make driving much safer. And that really applies to everything else. And that is why focusing only on individual behavior is a recipe for us to continue to have poor health. Another illustration of this recently is our notion, which is broadly false probably, that once we understand our genetic risk factors, we will change our behavior. In fact, science is emerging on this. This shows that once you understand your genetic risk, it does nothing for your behavior. You still behave the same way. So when we understand that, we realize that efforts that are purely behaviorist are doomed to fail. Now, don't get me wrong. Ultimately, my health and your health is influenced by whether or not we run, whether we eat healthy. But telling us to run and telling us to eat healthy in and of itself is not going to be sufficient.
Gotcha. So how does that approach translate to kind of a public health approach to mass violence? What would such an approach actually look like? I think people might assume, oh, they're going to talk about gun control and so forth, but are there other aspects to a public health approach to mass violence that are relevant?
Yeah, I think a public health approach to mass violence asks the broad question: what are the social and economic conditions which are creating the exposure to trauma, and what are the conditions that then mediate the consequence of the trauma? One of the biggest, I think, shifts in our thinking about trauma and its consequences is that it's not trauma just happens, everything's okay before, and then there are consequences just of the traumatic event. The traumatic event is embedded in our lives. It is a function of the world around us, and its consequences reflect not only the traumatic event, it actually reflects prior life experiences. So now we know that whether or not I have bad experiences, bad mental health or physical health after a traumatic event, depends on the traumatic event, yes, but also on my childhood experiences. Also depends on my social and economic conditions, on whether or not I actually have other stressors. We've done work after many large-scale traumatic events, for example, showing that what matters to one's health is not just whether or not somebody was in a hurricane, but whether or not they actually have housing, whether or not their children are in schools, whether or not they have ways to look after their parents. So a public health approach to mass trauma says, how is the trauma embedded in our lives, and how is it part of the full life course set of exposures from birth all the way through early childhood, through adolescence, through young adult life, through middle adult life, and the full set of factors that include not just my behaviors, but where I live, where I work, where I play, my social networks, the policies that support me, and the full set of organizational and policy structures that shape my life. So really we have to think of a life course perspective, which means we're thinking about health is generated at every stage throughout life, and an ecosocial perspective, which is the levels of influence that ultimately shape our health.
Mm-hmm. So that's just a remarkably different way of thinking about health and thinking about health promotion than we currently have here in the field of violence or in the field of disease prevention or anything like that. What suggestions do you have for, if any, I mean you're not required to know everything, for how people can actually start that shift?
Well, I think we start that shift by talking about it differently. I just published a textbook called Public Health: An Introduction to the Science and Practice of Population Health, which is really intended to be an introductory public health textbook, which really takes this approach that we just discussed, which is thinking about health as a product over the life course and thinking about health as something that emerges from a full ecosocial lens. And I do think that insofar, Dan, as you said, and I agree with you that this is a remarkably different lens than we typically take in the field of traumatic stress studies. It just means that we haven't had this conversation long enough, because to my mind, what I'm saying is self-evident. Mm-hmm. It is self-evident that health is a product of the full set of lifetime experiences and the product of the full set of influences in the world around us. I'll tell you one other metaphor that I use also in the book, which is the metaphor of goldfish in a goldfish bowl, where you have goldfish in a bowl and you want your goldfish to be healthy, so you tell them to exercise. You tell them to swim around your bowl 10 times clockwise, 10 times counterclockwise. And when you feed them goldfish food, you tell them not to eat too much. And when the goldfish are sick, you get them a good goldfish doctor. But the goldfish still die one day. And you say, why did they die? They exercised, they ate well, they got a good doctor. Well, the reason they died is because you didn't change their water. Mm-hmm. So the water is a critical part of why goldfish live. And that doesn't obviate the fact that the goldfish exercising and eating well was important. It simply says that the water also matters. So this goes back to thinking about trauma as part of a full set of context. I was thinking about trauma as part of the full set of life experiences influenced by what I'm calling the eco-social set of experiences about where we live, where we work, where we play, and what happens to us in our houses, in our schools, in our places of employment.
Yeah, that was a really powerful metaphor. And for anyone who's listening who sort of doubts the just sort of like Sandro said, the self-evident logic, I just would refer you to the book, what we need to talk about when we talk about health. It's an enormously accessible, easy to read, and amazingly persuasive way of discussing and illustrating a lot of the issues that we've been talking about today. Sandro, I know that you're very busy and that you've got a lot of stuff going on up there at BU. What kind of stuff is next for you? Are you working on another book?
I have a book coming out in a couple of months with a colleague here, Dr. Michael Stein, which is called Pain: The Uncomfortable Conversations About the Public's Health, and it is 75 pieces, each of them under 500 words. It's really intended to be a very bite-sized compendium that actually tackles some of these topics, and intended to be for busy people. You can sort of choose any essay under 500 words, trying to make some of these points. And actually, as I'm thinking about a conversation, I actually think that anybody who's listening to find this interesting might find this interesting, because it's really intended to say, look, how do we nudge the conversation on what health is forward?
Excellent. Well, I, for one, will certainly be looking forward to that, and I suspect a lot of our listeners will too. I just want to thank you so much for your time, Sandro. We've been talking with Dr. Sandro Galea, the Dean of the School of Public Health at Boston University, who's told us a lot about public health and how it relates to violence and how we need to think about health promotion differently. Thanks so much for your time, Sandro. We really appreciate it.
And a pleasure talking always.
All right. Bye-bye. This is Dan Smith, the Director of Technology and Resources for the NMVVRC, and we'll be back soon to talk with you and another interesting guest. Thanks very much.